Well, I'd like to welcome everybody today. This is the Baltimore County Fire Department Emergency Medical Services EMS training. Uh, Tonight's topic will be environmental emergencies, how to treat that cold, hot, and wet. Our lecturer today is Dr. Cheyenne Falat. She is the Assistant Medical Director for the Adult Emergency Department at the University of Maryland Medical Center down in Baltimore. She serves as the emergency medicine faculty at the University of Maryland School of Medicine and assistant medical director, again, in the adult emergency room. She attended medical school at the Icahn School of Medicine at Mount Sinai and completed her emergency medicine residency, chief residency, and faculty development fellowship at the University of Maryland. She's local. She has a passion for environmental medicine, procedural education, and patient safety and flow, and has published and lectured extensively on these topics. We're going to add environmental emergencies to that. Outside of work, you'll find her, or might not, as she likes to go skiing and a lot of international travel. So without further ado, welcome and thank you.
Thank you. Awesome. So, welcome, guys. This is a topic that is very, very important to me and a passion of mine. It might seem a little weird since I work at an inner city Baltimore, but we get patients from environmental emergencies all the time, even in Baltimore. And all of the cases today that we'll discuss, I've either had them as my personal patients or have seen patients just like them as well. So what I have on deck tonight is to talk about treating hypothermia, hyperthermia, and drownings. If we don't get through everything, that is fine. I would much rather have this be the way that you guys want to take it. So please interrupt me at any point, come off mute as I don't see the chat. Ask whatever questions you have, interrupt me at any point, and let's make this more of a kind of conversation rather than just a lecture, because I'm going to get tired if it's just me talking for 2 hours. So please interrupt me at any point, and we will go through it. Any questions before I get started? Awesome. And this is, sorry to go back a slide. Shout outs to Jeff Nussbaum over here on the left side of the ambulance, who was actually a resident up at Mount Sinai when I was a medical student there. So he taught me how to place my first IV, and then the famous Ben Launer, who's a dear colleague of mine and trained me up. So, starting off with resuscitating hypothermia. So I met Robert one February evening back in, I believe it was 2018. And we had kind of very different plans for the evening. I was about 18 hours into a shift at shock trauma, and Robert decided to go on a walk after engaging in an evening of polysubstance abuse just along the Baltimore City Harbor. And that is when some bystanders saw him kind of stumbling and fall into the water surface, becoming entirely submerged. They immediately called 911 and search and rescue teams were immediately dispatched. And it was a relatively warmer February evening, but the water temperature was still at 4 degrees Celsius, so quite cold. Once the crews were dispatched and the dive team mobilized, it took them about 25 minutes of searching underwater until they were able to locate Robert and pull him up out of the water. And of course, by then he was in arrest. He was intubated on scene. The Lucas chest compression device was applied, and he was brought to us at shock trauma with about a 5-minute ETA, chest compressions ongoing, active code. And what was communicated to us was that he had fixed and dilated pupils, he was cold, he was underwater for 25 minutes, and the trauma team, as we were receiving him, a lot of the people said, "Why don't we just call it?"
So your woman did.
Basically futile resuscitation at this point. But the kicker was that when he came to us, his core temperature was 26 degrees Celsius. And we know the mantra in emergency medicine, you're not dead until you're warm and dead. And we'll talk later what happened to Robert at the end of this. So a few things that I want to cover with you guys today is really the significance of why we do these heroic resuscitations for hypothermia and hypothermic arrests. We'll talk a little bit about the terminology and physiology of hypothermia as well. We'll talk about extrication and some ACLS modifications for hypothermia, some rewarming strategies, and then we'll go through recent literature updates that I think are more relevant to kind of the pre-hospital realm necessarily than what happens after we get these patients in the emergency department. But if there are any questions along the way, again, please unmute, ask away. And all of this that we'll talk about today is with the big caveat that this is what latest kind of research updates show. This is what we teach in emergency medicine. But pre-hospital, I understand that you guys still have your protocols dictated by your kind of offline and online medical direction. And so I don't want to encourage anyone to deviate from protocols, but perhaps ask questions. And if some of this stuff isn't incorporated into protocols, maybe it's time that we rethink that. So let's talk about why we do this. So this case that I shared with you is from right here in Baltimore. It was a real patient of mine, but also there have been extraordinary cases from all around the world. So Tromsø, Norway was where the patient with the lowest core temperature was found that was successfully resuscitated at 13.7 degrees Celsius. And this patient went on to make a full neurologic recovery. Going over to Italy and the Dolomite Mountains, this is where the patient with the longest CPR and ECMO low flow time combined, from which they were successfully resuscitated, of 8 hours and 42 minutes. And that was after a nearly half an hour no flow time when the patient was in arrest. So that's almost like over 9 hours of no flow and then low flow time, and the patient went on to make a full neurologic recovery. Another hypothermic arrest out of Regina, Canada, in the British Rockies was the highest potassium in a child from which resuscitation of a hypothermic arrest was successful, and that was 11.8. So we'll talk about later on in the lecture why we've used a classic potassium cutoff of 12 in order to pronounce some of these resuscitations even prior to rewarming them. It is because this child was successfully resuscitated from an 11.8, so we just arbitrarily used to set the cutoff of 12. In a adult, the highest potassium that we've ever seen from which a hypothermic resuscitation was successful was a potassium of 9. In Vienna, Austria was the lowest pH from which resuscitation of a hypothermic arrest was successful, of 6.29. This is profound because really anytime anyone is significantly acidotic, the outcomes are much worse and mortality is higher. And definitely under 7 is where we are really concerned. So 6.29 is very low. And they still survived. There was a fjord in Denmark in which a ferry boat overturned, leading to a lot of people kind of in the cold and frosty waters. There were 7 simultaneous cases that were put on ECMO at the nearest local hospital, and all of them survived. All the hypothermic arrests who received ECMO. Second to lastly, in Grenoble, France, there was the longest avalanche burial leading to a hypothermic arrest from which a patient ultimately survived was 7 hours. And I know that avalanches have been talked about a lot in the news lately with significant avalanches in Italy, in France, out in California, and now up in British Columbia outside of Revelstoke as well. So it's a very avalanche heavy season this year, and over 100 people have already lost their lives just in Europe alone from avalanches this season. And then lastly, in Gothenburg, Sweden, was the longest submersion time underwater from which someone was successfully resuscitated after a hypothermic arrest of 83 minutes. So all of these extremes are why we say you're not dead until you're warm and dead. Why we rewarm these, because these are profoundly abnormal labs and temperatures and no flow times, and many of these patients go on to make a full neurologic recovery. So in review, people even with severe hypothermia, prolonged downtime, and critical derangements can survive with good neurologic outcomes. So we want to make sure that we are offering kind of a full core press resuscitation to anyone in hypothermic arrest. So let's talk about hypothermia, backing up for a second. What is our normal core body temperature? Tends to be about 37 degrees Celsius, plus or minus about half a degree Celsius. And the reason that we are basically able to stay within these range is kind of threefold. One is that we have generally stable environmental temperatures at which we can sustain this. So when we see like this cold stroke that we've been having in Baltimore in January and February when it was so cold for so long, people start to not really be able to maintain their core temperatures because that stable environmental temperature kind of we fall out of that range. Next is generally predictable human behavior. So if it's cold, we dress warmly. If it's cold outside or rainy or snowy, we go indoors. That is generally predictable human behavior. And then lastly, we need to have a functional autonomic nervous system. So there is a small part in our brain called the hypothalamus, and that's what kind of senses our cold and heat inputs. And then it causes us to behave in certain ways based on that temperature sensation. Now, there are reasons why this fails and why people become hypothermic. So, obviously, environmental exposure to extreme cold, like we were having in Baltimore in January and February, like they have in the snowy mountains or in avalanches. Generally, the longer you are in the cold, the harder your body works to maintain warmth, and over time it fails. Then general medical diseases can contribute to someone developing hypothermia. So people who are septic or fighting infections or people who have hypothyroidism to begin with, that messes with your temperature set points. And so if you're already predisposed to get cold, then developing hypothermia is even easier. People who are under certain pharmacologic intoxication, so people under the influence of alcohol or opiates, people who are on anesthetics, like this doesn't just happen outside of the hospital, people can get a little hypothermic. It's not environmental hypothermia, but hypothermia can happen from certain anesthetic agents as well. And then other medications that either disorient or dehydrate or can lead to like bradycardias. All of that is influences our body's ability to maintain its physiologic responses to cold. And then people with certain neurologic conditions, such as dementia, that clouds your judgment, and you just don't know when you should get dressed into warmer clothing, or you wander away from your house and you get lost outside. People who have had prior strokes or issues that impair their mobility, so maybe they can't get around their house, they can't get better clothed, they fall outside and they can't get up, and then are left on the sidewalk or on the in the grass or on the path. Patients who have difficulties with thermal sensations, such as like peripheral neuropathy or end-stage diabetes, where they start losing that ability to sense hot or cold. And then lastly, people with, for instance, spinal cord injuries or patients who have impaired responses to cold. So maybe they can sense cold, but their body doesn't react the way that it should. So people can get hypothermic because they're predisposed due to any of these things, but also sometimes the environment just wins if you try to fight the environment. So when we talk about what is hypothermia, that's when we have a core temperature less than 35 degrees Celsius. And then we further split this into three stages: mild, moderate, and severe, with the mild hypothermia being in that 32 to 35 degree range, moderate being in that 28 to 32 degree range, and then severe hypothermia being less than 28 degrees Celsius. And each one of these stages comes with certain hallmark physiologic responses. So when you are in mild hypothermia, again, that 32 to 35 degree range, our periphery, like our skin kind of thermal receptors, are able to sense the cold, and then it triggers that hypothalamus, that part of the brain, to trigger a catecholamine response. And what this is it's a sympathomimetic or a ramped up response. So people get tachypnic, they get tachycardic, their cardiac output increases, their blood pressure goes up. It's basically our body trying to get us more active to warm us up. This is where you'll see some peripheral vasoconstriction. And then shivering, and that shivering can oftentimes affect kind of fine motor skills, and they can get a little stiff. And as I mentioned, you'll experience tachycardia, tachypnea, increased cardiac output, and some hemoconcentration already in this stage. So think of mild hypothermia as really your system is ramping up because your body senses that it's cold and it's trying to really kind of shake you up and trigger you to get moving and to get warm. Shivering is actually our body's natural response by which it tries to warm us up, and it's quite effective. But as we'll talk about later, you need to have certain caloric stores and not be kind of emaciated or cachectic in order for that shivering to work, because you need the calories to shiver. So as you move into moderate hypothermia, the shivering stops and you experience kind of an overall return of that catecholamine surge, that ramped up surge to pre-hypothermic levels. And then it continues on slowing. So everything that was previously ramped up when we saw the tachycardias, the tachypneas, the kind of shivering and increased kind of jitteriness, we see slowing of all of that. So we see that those tachycardias kind of degenerate into bradyarrhythmias. People will start to hypoventilate. They'll become lethargic. Sometimes they'll become kind of drowsy, ataxic, even lose consciousness at this stage. You might see an early moderate hypothermia, this phenomenon called paradoxical undressing. So there are changes to the patterns of blood flow, and people may actually get a perceived sense of warmth and then have a response to shed a layer of clothing. That is quite dangerous because your body's actually getting colder that way as well. And then oftentimes people will experience significant cold diuresis. That will dehydrate them even further. And our platelets start to become dysfunctional at this stage. And that is why you see worsening kind of bleeding. And if they are injured, they might not be able to clot and stop their bleeding as easily. As this further degenerates into severe hypothermia, that less than 28, everything that was slowing eventually stops. So this is when you'll experience even worsening neurologic depression and coma until you essentially lose all brainstem reflexes. That Bradypnea will degenerate into apnea. People will have pulmonary edema. You'll experience fatal dysrhythmias, so that those kind of bradyarrhythmias will degenerate into ventricular fibrillation or very even fine VFib that's oftentimes mistaken as asystole initially, but ultimately it can degenerate into asystole as well. And then you'll have decreased enzyme activity, particularly of the liver enzymes. So that is why some medications, such as epinephrine, may not be as effective in resuscitating these people. And then you'll see even bigger problems with the coagulation cascade. People will develop DIC, which is where your body is kind of overwhelmingly bleeding and clotting at the same time, and everything is in disarray. And the way that we see that is they just start bleeding out of all of their orifices, essentially. This can also happen as a complication of a heat stroke as well, and same with the rhabdo. So in review, mild hypothermia, that initial stage, everything starts to ramp up your body's responses. Then moderate, everything starts to slow. And in severe hypothermia, everything kind of stops and people will appear dead. But how do we know which stage of hypothermia the patients are in? Well, it's a little bit difficult to tell pre-hospital because mercury and alcohol thermometers, which is historically the mercury thermometers are the ones with the silver. Alcohol thermometers are now what we see with the red ink. And then all of our digital thermometers are generally inaccurate, the literature shows, beneath about 36.5 degrees Celsius. So even before we get into mild hypothermia, a lot of those measurements will start to become inaccurate. So how do we get accurate core temperatures? Well, once the patients are in the department, we can place either an esophageal probe if they're intubated into the distal third of the esophagus, or a rectal probe, with the caveat that it must be at least 15 centimeters deep in order to get a core temperature. And then the literature will talk about epitympanic probes. Now, those are not these that kids, like we measure a kid ear temperature with. but they look more like this. So a lot of times they'll use them in operating rooms or different search and rescue crews that work like in avalanche rescue and in the backcountry will carry these on their rigs as well. They're called the epitympanic probes, not the tympanic probes. And the caveats being the external auditory canal, so your ear canal, has to be dry. There has to be no impacted snow or earwax. There has to be an adequate seal, and there has to be an isolating cap against the cold. So that thing, that blue thing that you see there. So important to know that that we don't always get accurate core temperatures. So can we assess core temperatures and temperatures clinically? So there used to be this thing called the original Swiss staging model for hypothermia. In which hypothermia was divided essentially into 5 stages with clear consciousness with shivering, impaired consciousness without shivering, unconsciousness, apparent death, and then death. Due to irreversible hypothermia. Again, that 13.7 cutoff was because the lowest temperature from which someone was successfully resuscitated was 13.7. There have been no cases of less than that. But the literature found that this was woefully inaccurate at predicting various stages of hypothermia. And shivering in particular the presence or absence of shivering was about 60% inaccurate. So we really couldn't make a determination about the core temperature based on the presence or absence of shivering. So they came out with this revised Swiss system for staging of accidental hypothermia. Accidental hypothermia and environmental hypothermia are oftentimes interchangeably used. And essentially, it doesn't come up with a temperature estimate, but it comes up with how likely are you to suffer a cardiac arrest due to this hypothermia. So if the patient is alert and talking to you, the risk of cardiac arrest is fairly low, even if their core temperatures are lower. So we had a patient at university just a couple weeks ago who was brought in because they had like foot pain was the triage concern. Ultimately, the patient ended up having frostbite, but they were alert. They were talking to us, and it turns out the core temperature was like 28.9. So quite cold, but alert. And so the risk of progressing and deteriorating into a hypothermic arrest was still considered low. If they are only verbal, then it's a moderate risk of cardiac arrest. And if they're only respond to painful stimuli, or they're unconscious and they have some vital signs present, the risk of deteriorating into a cardiac arrest is quite high. And if obviously they don't have any detectable vital signs, then we consider them a hypothermic arrest. So original Swiss staging model out. It was relatively inaccurate, inconsistencies, but the revised Swiss staging system tends to do better at estimating cardiac arrest risk. So in review, mild hypothermia, everything ramps up. Moderate hypothermia, everything slows down. And severe hypothermia, everything stops. Questions so far before we move on to the next? All right. Hearing nothing, I will go on. And again, please feel free to interrupt me, stop me at any time. I know I talk fairly fast, but hopefully it keeps you guys engaged as we go into the evening. So when we talk about extrication, few important things to know about hypothermia. There is this phenomenon called afterdrop that's theorized but also reported on in the literature, in which it's the continued cooling of a patient's core of up to 6 degrees Celsius even after they're removed from a cold environment. So you can imagine that is enough degrees Celsius to really span the whole range from moderate to severe hypothermia. And this happens because there may be continued heat dissipation, meaning heat loss, and it can be worsened by things that increase someone's peripheral blood flow, because generally the extremities are going to be colder than the core, just because they have more exposure to the cold. So if we suddenly do something that increases the blood flow to those extremities that are colder, and then that blood flow does return to the core because their heart is pumping, then that will continue to cool their core. There is another phenomenon called circumrescue collapse. It's a phenomenon in drownings, but even worse in hypothermic drownings, in which there is a the patient has a syncopal episode or sudden death as they get rescued. And this is theorized to be because of a few different things. One is they have kind of mental relaxation because they think, oh, the team's finally found me. They're finally coming to rescue me. I'm safe. I can relax. And that decreases the catecholamine surge, meaning that kind of ramped up response that people get, that sympathomimetic response. And sometimes that is all that is supporting their blood pressure and their heart rate. So as that catecholamine surge falls, then they can really bottom out their heart rates and blood pressures to the point when they can have a syncopal episode or a sudden death. Lastly, as they're removed from the water, if they're already a little hypotensive to begin with, that water was actually providing pressure in a sense in order to keep their blood flow not pooling like in their periphery or not pooling in their in the kind of tissues outside of their blood vessels. So when you lose that extra hydrostatic pressure, that's usually that's exerting some force on the body, that can lead to further venous pooling and blood flow away from the heart and the brain, the tissues that need it most. And then that positional change, kind of oftentimes, if they're in the water, they're still alive. They're trying to support themselves. They're trying to just lay on their back and maintain their breathing. But then as they're rescued, they're oftentimes lifted up out of the water in a vertical position that leads to, again, venous pooling in the blood vessels in the legs, and that can drop your cardiac output. So we try to extricate these people in as much of a horizontal position as possible in order to prevent this circumrescue collapse phenomenon and that after drop phenomenon. So be very careful when rescuing these folks. Now, classic signs of death, it's important to remember, are not contraindications to resuscitation in severe hypothermia. So patients with apparent rigor mortis, that kind of fixed frozen tissue, fixed and dilated pupils, and this kind of purplish discoloration of the skin, which we call dependent lividity. We tend to see it in the dependent areas of the body. So like if they're lying on their back, it develops really along their back. None of these are contraindications to resuscitation for severe hypothermia. Some of them may be considered contraindications for a normothermic person, but not hypothermic person, because patients with all of these classic signs of death have been resuscitated with full neurologic outcomes. Next, as we mentioned, in severe hypothermia, when we talk about pulse checks, patients can have just such profoundly bradycardic and hypotensive responses that, again, that pulse might be hard to pick up. It might be hard to pick up on a pulse of like 18 or 22. It might be hard to pick it up when their blood pressure is 60/40. So literature actually recommends that instead of that 10-second recommended pulse check, if you have high suspicion for a severely hypothermic person, so they're like an avalanche rescue or found down on the street in Baltimore and it's 10 degrees outside, like it has been recently, perhaps considering a 60-second pulse check, really to make sure that there is absolutely no cardiac activity prior to initiating CPR. And this is because if you do start compressions or if you do start pacing these people and they did have some intrinsic activity, regardless of how hypothermic or bradycardic they were, you can actually precipitate a fatal arrhythmia. You can precipitate ventricular fibrillation by trying to do CPR or trying to do pace them, because severely hypothermic heart muscle or myocardium is very, very irritable. So any kind of like jostling it around can actually just tip it over into VFib from an organized rhythm. Now, when we talk about CPR, this is, again, in order to do some of these extrications. And I don't know how many of you guys are lifelong in this area, how many of you will go on to maybe do search and rescue operations or work in the backcountry. So I'm going to touch on a little bit of kind of more rescue stuff from difficult to rescue scenarios. But in the literature, there is an allowed up to 10-minute delay in starting CPR if needed to extricate the patient, if needed to like pull them out of a crevice or get them out of their avalanche burial. And then while you transport them, if you cannot do continuous chest compressions, then literature does support kind of a 5 minutes on, 5 minutes off recommendation in which you need to do CPR or like continuous chest compressions for at least 5 minutes at a time and pause for at most 5 minutes at a time. And the reason that we can do these modifications and still have good neurologic outcomes is because for every 1 degree drop in your core temperature, and again, remember that core temperature is about 37 degrees Celsius usually, and these hypothermic or the severe hypothermia where people generally arrest is under 28. So they essentially all have 10-degree drops at least in their core temperature. And for every 1 degree drop, we have a decrease in your oxygen consumption by the body by 6%. So essentially, someone who is in arrest from severe hypothermia will have at least just half of the oxygen need that a normothermic patient has in a similar situation. Moving on. So we already talked about how we don't want to pace bradycardia. So if they are maintaining any kind of perfusing rhythm whatsoever, as I mentioned, even if they are profoundly bradycardic to the 20s, they're profoundly hypotensive to the 60s over 40s or whatever it might be, that is still probably enough support to keep up with whatever minimal perfusion, oxygen perfusion they actually need. And so because we don't want to risk tipping them over into a fatal arrhythmia that doesn't really provide any support or any significant oxygenation to their tissues, we want to actually leave them in their bradycardic state. Other EKG changes that we may see, again, in mild hypothermia, we might see sinus tachycardia, then sinus bradycardia, and atrial fibrillation with a slow ventricular response is actually a very common rhythm for patients with moderate to severe hypothermia. It doesn't really portend any kind of outcome, and generally this rhythm resolves with rewarming and people go back into that sinus rhythm. And then that eventually deteriorates into ventricular fibrillation and asystole. Uh, if you get an EKG on people, you might see what's called these Osborne waves. They are essentially like an upward notch at the end of a QRS complex. It's oftentimes seen and mostly reported in the literature with hypothermia, but there can be other conditions such as hypocalcemia in which we see that too. So that kind of extra notch after the QRS complex is called an Osborne wave, and that if you already suspect that someone is hypothermic, seeing this on an EKG should help you kind of confirm your suspicion. Next are defibrillations. Well, what do we do when someone is with a core temp less than 30 degrees Celsius? There are a lot of different recommendations. So back in 2014, the Wilderness Medicine Society recommended multiple defibrillation attempts, but waiting for a 1 to 2 degree rise in core temperature between each defibrillation attempt. Then the Wilderness Medicine Society came out in 2019 with updated guidelines that just said defibrillate one time, and if it doesn't work, just wait until their core temp has rewarmed to 30 before trying anything else. And then in 2021, the European Resuscitation Council said defibrillate up to 3 times as long as the core temperature is below 30, and then hold any further defibrillation attempts until they're rewarmed to 30 degrees Celsius. Because the thinking is, if it doesn't work once, if it doesn't work twice or 3 times, it's not going to work because that myocardium is so irritated and so kind of resistant to tipping back into a perfusing rhythm. So essentially, there are conflicting guidelines and recommendations on what to do. So really just follow what your local protocols dictate, but know that it's probably reasonable to defibrillate once, twice, 3 times, whatever it might be. But definitely not more than 3 times, or else you're just kind of trying to fry them warm, I guess. And it's really not doing anything. And it can be kind of detrimental to the tissues as well, where those pacing pads are. So if it doesn't work after 3 times, don't try anymore under 30 degrees Celsius. If you're under 30 degrees Celsius, so again, you might not be able to recognize this pre-hospital unless you have one of those epitympanic probes and all those caveats are met. But if for some reason you do know the temperatures, then this is where these guidelines are kind of useful. So as far as epi, in 2020, the AHA said do standard ACLS. So use epinephrine at routine ACLS doses. But both the 2010 and the 2021 European Resuscitation Council and the 2019 Wilderness Medicine Society guidelines say not to give any vasoactive medications under 30 degrees Celsius. And because the two major organizations that focus on accidental hypothermia both recommend against it, my take is generally not to do any epinephrine because the myocardium isn't really sensitive to epinephrine at temperatures this cold. And what you're doing is just leading to a buildup of epinephrine. And then once the body does become sensitive to it, then it's kind of overwhelming and oversurging the system with epi. So there's really no good data to support the use of epinephrine as long as you have core temperatures less than 30 degrees Celsius. When they're rewarmed in that 30 to 35 degree range, the AHA says, standard ACLS, full core press. And again, both the European Resuscitation Council and the Wilderness Medicine Society says do it, but double the dosing intervals. So give it at like every other interval that standard ACLS would recommend. And then, as far as what you may anticipate with airway protection challenges, so intubations, is I anticipate some degree of trismus, but not trismus because they have like a dental abscess and they can't open their mouth, but trismus because the tissue is literally frozen. It's like if you were to try and pry two frozen chicken breasts off each other, right? You might not be able to. People might be so frozen that it might be difficult to open their mouth in order to intubate them. If you are able to intubate them successfully, consider slightly underinflating that cuff on the ET tube because as you rewarm the patient, that also rewarms the air in the cuff and warmer air expands more. So that cuff will expand as the patient is rewarmed, and we don't want that cuff to overexpand and then lead to pressure necrosis along the trachea. When we have them intubated and we are bagging them, you want to slightly err on the side of hypoventilation. If you hyperventilate these patients, that can lead to further cerebral vasoconstriction, meaning clamping down of the vessels in the brain, and that might lead to somewhat worsened neurologic outcomes. So, if anything, err on the side of hypoventilation. And then again, medication dosing. So you want to lessen the dosing intervals of your medications, of your paralytics, of your induction agents if you are intubating with medications. So essentially, in review, do not pace bradycardia if you know that they are hypothermic. So if the story is like overwhelmingly convincing that you have a hypothermic patient, like a severely hypothermic patient. Don't pace them. Avoid epinephrine for patients with core temperatures less than 30, and then anticipate that you may have some difficulties with securing people's airway. Any questions before I move on? Any explanations, further explanations? All right. Hearing none, I'm going to go on. But again, please, I will be annoying in saying this. Please unmute and ask me whatever you want because I'm not really, I don't have the chat up. So if you have any questions, just ask. We're going to get into some rewarming strategies. I know that that some of this may be foreign to you guys because a lot of this deals with what we kind of do in hospital. But I know sometimes you guys like to kind of hang out and see what we do, and so this hopefully will help tell you why we do what we do, and also why we ask for specific information from the pre-hospital crews when they bring us patients to the emergency department in hypothermic arrests. So we have a variety of strategies of how to rewarm patients. Passive rewarming is what happens kind of when we remove the patients from the cold. So you bring them to us, we take off their cold clothing, we give them warm blankets, and we allow the body to kind of shiver and to passively rewarm. That can raise the core temperature by about 1 to 2 degrees Celsius per hour, but these patients have to have adequate caloric stores. So the patients who are profoundly septic or hypoglycemic or cachectic, or they have end-stage cancer or whatever it might be, and they're not really nutritionally ideal, these patients will not be able to reach these passive rewarming rates because they will not have the calories needed to shiver. Next is we do active external rewarming. So that's like when we put the forced air device on the patients. I don't know if I'm allowed to say bear hugger because that's what we use. There are more different brands. I am by no means endorsing bear hugger, but any kind of these devices that kind of blow warm air at these patients. That is active external rewarming. And that can raise the core temp up to 1 to 3 degrees Celsius per hour reported in the literature. Next, we are able to do bladder or gastric lavage. So it can either be done kind of continuously if you have a special kind of Foley catheter or a special kind of OG tube, but we can also do this in dwells where we'll instill up to about 300 cc's of warmed fluid we warm it generally to about that 41 degree range. We let it sit for 20 minutes and then pull it back out. That can rewarm up to a degree per hour. Peritoneal lavage, really not done anymore. It used to be done, I think, more commonly when people used to do more diagnostic peritoneal lavages, such as after traumas. It's where you essentially make an incision into the abdomen and just go into the peritoneum or into the abdominal cavity and kind of just slosh around warm fluid in there. But as we've lost our skills in diagnostic peritoneal lavages, where we used to do that to instill some water and then remove, or a normal saline, and then remove it back out to see if there was any blood in there. That's how we would assess for intra-abdominal bleeding after traumas. Now we use ultrasound a lot. So we do fast exams or looking for intra-abdominal blood. And as our skills to do the diagnostic peritoneal lavages have fallen off, then our skills to do peritoneal lavages have fallen off as well. But what you'll still sometimes find people doing out in the community hospitals are thoracic lavage. So you'll see chest tubes being placed to rewarm patients with hypothermic arrest or severe hypothermia. But more recently, we have seen increased use, especially at academic centers or centers that have neurocritical care or cardiac surgery, because these are oftentimes used kind of procedurally and kind of in their postoperative care are these things called endovascular rewarming catheters. So it's essentially a closed loop circuit wrapped up in a central line. So you'll see the docs placing this is a regular femoral central line, but it has tiny balloons on the outside of the catheter. And this machine warms normal saline. It circulates through those balloons, warming the blood that's passing around it, and then cooling off in that process. And then the cool fluid is circulated back to the machine to be rewarmed. And that can actually rewarm patients up to 2.5 degrees Celsius per hour. And all of these rates are additive. So we tend to do more of these things at once. And then patients can get CRRT, which is essentially kind of continuous dialysis. So especially people who already have dialysis catheters can be hooked up on their CRRT device that we can get in the emergency department, and that circuit can rewarm people up to about 3 degrees Celsius per hour. And then ECLS, and ECLS is essentially ECMO cardiac life support. So it's with this device that essentially takes over the functions of oxygenating blood. And that device, as the blood passes through that circuit and pumps for the patient, can also rewarm them. The literature rates report up to 10 degrees Celsius per hour, but more recent literature has shown that the optimal rewarming rate seems to be about 3 degrees Celsius per hour. So ECMO is the kind of gold standard for hypothermic arrests for appropriate patient populations. And so how do we decide which patients get ECMO or get ECLS? Historically, for patients with severe hypothermia and any number of indications, we have really really considered ECMO. So, are they in cardiac arrest? Do they have respiratory failure? Are they really acidotic or really hypotensive or have a life-threatening arrhythmia, such as the profound bradycardias? There was a study in 2023 called the ICE crash study. It was a large multi-center prospective observational study in Japan. And studies in environmental medicine are fairly hard to come by because we don't oftentimes have kind of case matched stuff or prospective. And oftentimes these cases happen with enough infrequency that it takes years and years and years and years to run a study. So this was a pretty big study. That showed we definitely want to consider it for cardiac arrest. It helps, but maybe not so much for some of these other indications. So there are some programs that have become a little more selective with who they offer ECMO to in severe hypothermia. When considering, though, not everyone in cardiac arrest from severe hypothermia will end up getting ECMO, and how do we decide which patients should get it? We use what's called the HOPE score. The HOPE score is a score calculated based on 6 variables, which is age, gender, CPR duration. So how long, not downtime, like when was the patient last seen well, but how long CPR has been in process for, what their core temperature is, their initial potassium, and whether or not we have suspicion for asphyxia. So, like, are they an avalanche patient with snow and ice impacted in their airway, and they physically, like, even if they were alive, they couldn't breathe because their airway was completely blocked? Were they strangled and left in a field to die? You know, these kinds of things weigh into this decision. So when we are kind of asking for assistance with some of these variables, it's because it's actually quite important in order to calculate out this score. And this score is what our cardiac surgery programs use to determine whether or not they should roll someone onto ECMO and help rewarm them. And we use this score because it found that an additional 27% of ECMO attempts could be avoided without any additional loss of life when using this score compared to what we used to use, which was just a potassium cutoff. So when we try to really harp on some of these things, it's because these variables are what oftentimes makes the difference between someone getting ECMO as a definitive therapy and not. Okay. So reasons for patients to be transported directly to an ECLS facility or an ECMO-capable facility, I would say patients in hypothermic cardiac arrest should be coming with us to us. We should be able to calculate out the scores. And then maybe patients at high risk for cardiac arrest from hypothermia. So core temperature is less than 30 degrees Celsius, systolic blood pressure is less than 90, or those who already have some kind of ventricular arrhythmias present. And then lastly, how do we know when to terminate these resuscitative efforts? As I mentioned, you're not dead until you're warm and dead, but sometimes even when warm, people stay dead. So if patients are still in cardiac arrest, like they have not gotten ROSC, when they've been rewarmed to 32 degrees Celsius or with a potassium level greater than 12. Now, I do want to touch on a special circumstance, avalanches. There have been so many avalanches this year. I don't know what it is about the weather patterns and precipitation patterns, but we're seeing them all over the place, from Canada to California to there was just one in Chamonix, France. There was one in Courmayeur, Italy, when the Olympics were starting. So we are seeing a very avalanche-heavy season. And the reason that avalanches are so fatal is kind of fourfold. One are as people get trapped in the avalanche, they get a lot of snow and ice that get impacted into their airway as they're falling. And so they literally sometimes become hypoxic because they can't breathe. Even if for whatever reason they don't have snow and ice impacted into their airways, sometimes with the avalanche itself and the intense pressure that can build up inside that avalanche, they can literally be squeezed so much by that surrounding snow and ice that they physically can't expand their chest enough to take a breath. And they essentially suffocate that way because they can't inhale because they're mechanically constricted from doing so. So hypoxia tends to be the leading cause of death in avalanche patients, followed by traumatic injury, so both penetrating and blunt trauma as they fall into trees and get impaled by twigs, get slapped against rock faces, etc. Hypothermia, so if they're still alive and if they survive the trauma of the avalanche, rescue operations can take a long time. Especially in remote areas or hard to reach areas, or even for people to know that someone is missing. So hypothermia can set in over time. And then lastly, if it happens at a high enough altitude, generally over about 8,200 feet or 2,500 meters, that's when they can develop altitude illnesses such as pulmonary edema and cerebral edema as well. So avalanches are quite fatal. Touching on that, there was an update in 2024 from the Wilderness Medicine Society for managing patients buried in avalanches and non-avalanche snow burial accidents. And they're saying essentially if the burial time is less than 60 minutes, less than or equal to 60 minutes, or their core temperature is greater than or equal to 30, like they're not in hypothermia or hypothermic arrest, really treat them as a standard resuscitation and provide advanced life support. If the burial time is greater than 60 minutes and their core temperature is less than 30 degrees Celsius and they have a patent airway, meaning they don't have that snow and ice impacted into their airway, start CPR and transport them directly to an ECMO facility. And then recommendations to terminate resuscitation if they still don't have ROSC after 30 minutes of resuscitation for burial times less than 60 minutes. So these are the patients who really haven't been buried all that long, but you start CPR, you're 30 minutes in. When to stop it is if their core temperature is greater than or equal to 30 and they have a non-patent airway, because probably they suffered a hypoxic arrest in that case and not a hypothermic arrest. If they have a core temperature greater than or equal to 30 degrees Celsius and they're pulseless or apneic, because essentially they've been rewarmed and they're still not in, and they're kind of no longer in that hypothermic arrest. Or if they're pulseless and apneic and they have an obstructed airway, again, because the thought is that they suffered a hypoxic arrest and not necessarily a hypothermic arrest. So lastly, in review, consider ECMO for hypothermic arrests, calculate out the HOPE score, and terminate resuscitations when we hit 32 degrees Celsius or a potassium greater than 12. So going into some recent literature updates, these are all studies that have been published since 2023 and onwards, so for the last 3 years. Hyperoxia. So should we be just ramping up the oxygen all the way up for patients who are hypothermic? And this is important because generally these are the patients in whom we don't get reliable pulse oxes, right? They have cold fingers, cold digits. We can't get good readings. So oftentimes our default is to just, slap them on a non-rebreather, ramp it all the way up, and give them all the oxygen we can. But maybe we shouldn't be doing this. So this was a kind of a follow-up study from that ice crash study that we mentioned, that Japanese study from 2023. And patients were excluded from the study if they had cardiac arrest already on ED arrival or they had no documented PaO2, so the oxygenation on labs that we find. So there were 338 eligible patients, 65 patients who the lab showed, like their ABG, their arterial blood gas, showed that they had been over-oxygenated, essentially. They had PaO2s greater than 300. And that was compared against 273 patients without hyperoxia. So they seem to have been normally oxygenated. So they looked at those who were hyperoxygenated, and they found that that group did have a higher 28-day mortality rate. So they actually did worse. And they found that the hyperoxia, or too much oxygen, was particularly harmful in certain subgroups. And that was in the elderly, in those with any kind of cardiopulmonary disease, so like heart disease, heart failure, those patients with stable vital signs, otherwise stable vital signs, or those with hypothermia less than 28 degrees Celsius, so severe hypothermia. So ultimately, they concluded that hyperoxia prior to rewarming was associated with an increased mortality, and we should be considering restriction of supplemental oxygen prior to rewarming in cases of accidental hypothermia. Again, I'm not advocating that you deviate from your guidelines at all, but this may be cases or literature that you want to discuss with your medical directors of various EMS systems. So then This was a study looking at CPR on ski slopes. So this was a crossover study at the Big Boulder ski area in the Poconos, right near us in Pennsylvania, in which they had a full torso commercial CPR mannequin, for which they made kind of makeshift appendages and dressed them in ski wear. And then they got 8 of their off-duty ski patrollers to participate in simulated resuscitations using manual chest compressions, like we see on the bottom left, or the mechanical CPR, meaning they had the external automated chest compression device applied. And they found that when comparing manual versus automated chest compressions, the fraction of time providing compressions, there really wasn't any difference. But the time that we were providing high quality CPR, meaning the CPR that actually works, was higher in that group that used the mechanical device, and that also facilitated faster extrication times. So time actually out of the initial scene and down to the mountain where medical care could be assumed by a crew that wasn't just the mountain crew. So compared with manual CPR, they concluded that mechanical CPR devices are actually non-inferior for use in ski areas during the resuscitation, extrication, and transport down a mountain of a patient to definitive care. This was a study that was done in an ice cave with volunteers. In, I believe it was Norway, in 2024, looking at whether we should be undressing patients to rewarm them or whether we should just be leaving them in their cold and wet clothing and then rewarming them. So they took healthy volunteers who were dressed in wet clothing and walked 100 meters to an ice cave. They were allowed to cool, their core temperatures cooled in this ice cave for 30 minutes. After that, one group had their clothes cut off. The other group had their wet clothes stay on. They were both maintained in a horizontal position. And then they were provided with a vapor barrier to keep like humidity on the body, warming and insulating blankets, and then finally a wind barrier on top. So they were kind of wrapped in a threefold warmth and vapor barrier, and then allowed to warm passively for 30 minutes. Lastly, they had at least 120-minute washout time between scenarios, and then they were subject to the opposite scenario. And what they found was that the mean temperature reduction in both the groups was about the same. So no difference in those two groups for how much colder they got during that 30-minute time. They did find that those who had their clothing cut off did additionally cool after that 30-minute mark during the period of time when their clothes were being cut off, but they actually had faster rewarming rates at 2 minutes and at 10 minutes compared to that group of people that were left in their wet clothing, and they had a much quicker return to a baseline core temperature, 12 minutes compared to 28 minutes. So they found that removing wet clothing prior to the application of that vapor barrier did lead to faster rewarming rates, but under certain conditions, such as extreme cold or high wind, maybe they said that that exposure time of clothing removal might come with some risks, so to be cautious in those scenarios. But either way, practicing removal of wet clothing can help minimize exposure time to additional cold and wind. Next were predictors of cardiac arrest in severe accidental hypothermia. So it was a multi-center and retrospective study of adult patients with severe accidental hypothermia, so less than 28 degrees Celsius, with preserved circulation at the time of first contact with medical services over the course of 21 years. They included 182 patients, 52 of which ended up suffering from a hypothermic cardiac arrest, 131 of whom did not suffer from any hypothermic cardiac arrest. And when they looked at those that did ultimately have cardiac arrest, they found that hypoxemia or low oxygen levels, hypotension, bradycardia, and ventricular arrhythmias were associated with developing cardiac arrest. When they looked at multivariate analysis, so like specific variables in the pre-hospital realm compared to the in-hospital realm, they found pre-hospital that bradycardia and ventricular arrhythmias seemed particularly indicative of someone going on to progress to a hypothermic cardiac arrest, and then bradycardia, hypoxemia, and base excess or associated with the inpatient or in hospital variables. So this goes on to conclude that bradycardia, hypoxemia, and ventricular arrhythmias appear to be most associated with the development of hypothermic cardiac arrest, and perhaps pre-hospital services should consider transport of patients with these particular abnormalities directly to ECMO-capable facilities for hypothermic rewarming. Next, touching a little bit on frostbite injuries as opposed to kind of systemic hypothermia. In 2024, the FDA announced that it greenlit the first medication known as iloprost to treat severe frostbite. When it's injected, the thought is that it dilates blood vessels and prevents blood clotting so that people who have frostbite have a lower risk of needing their fingers or toes to be amputated. Interestingly, Bayview, Johns Hopkins Bayview, is the only hospital in this area that has iloprost on formulary. So they would be the only hospital capable of administering this therapy. Next is Wilderness Medicine Society frostbite updates. So again, just a quick review of the different grades of frostbite. So grade 1 is just the distal kind of fingertips look maybe red, maybe white, but there's no duskiness. Grade 2 is that the fingertips or distal parts of the fingers, so past the last joint, are dusky. Grades 3 frostbite is that the whole finger can appear dusky, so into the middle or the proximal part of the finger. And then grade 4 frostbite is when that duskiness on initial contact extends into the carpals or the tarsal bones into the foot. So proximal to the fingers or toes. So they said absolutely avoid refreezing if absolutely avoid, this should be rewarming if or refreezing if field thawing occurs. So if you start a thawing or a rewarming process, you don't want there to be any chance of refreezing after that. So sometimes the mistake will be made that people are out in the wilderness, they're hiking, they get frostbite, they go to a base camp, they rewarm, and then they go out into the freezing temperatures again and refreeze. That freeze-thaw cycle repeating is what causes a lot of inflammation and injury and leads to increased amputation risk. So you want to avoid refreezing if you start thawing. You want to wrap circumferential dressings loosely to allow for some edema. We want to consider IV or intraarterial TPA, like the same stuff that we use for strokes. Now we're using tenecteplase. For severe frostbite, meaning grades 3 or 4 within 24 hours of injury, especially if iloprost is not available. If iloprost is available, we want to consider it for any time patients present with any kind of duskiness, so that grades 2 through 4 frostbite, and this is why it's important to really consider Bayview as the referral center for frostbite patients as well as burn patients. I don't know if they know that I say that, but they're really the only ones who can provide that iloprost therapy. And then
I had a quick
lastly,
question.
I'm sorry?
Hey, I didn't mean to cut you off. I had a quick question.
Yeah, of
So I do a
course.
lot of camping. I do snowboarding and stuff like that. So I'm kind
Yep.
of outdoors a good bit, and I'm kind of new to the medical field. I'm actually this is like one of my first times getting into a Zoom call with you guys.
Awesome.
Um,
Welcome.
I appreciate it. So in a scenario where you're rewarming, say you can't get to a emergency facility or something like that, and you're
hmm
actually out and about in the wild, so how long do you want to keep it warm before, you know what I mean? Like, how long do you want to keep the warm process going before you can actually go back out into the wild? Say if you had to get out of a scenario where you're trapped or something like that, and you start the warming process, and then you might actually occur or come into an area where you're getting cold again. Like, how long do you want to stay in the warmth, say if you're by a fire or something like that, before you keep moving?
Yeah, so the way that we recommend rewarming of true frostbite injuries. Now, if you're just cold and you want to warm up by a fireplace, by all means, go ahead. But once you start to see that duskiness, they recommend against kind of just radiative rewarming. So against like being by a fire or something like that. This is where we want to use immersion warming because as we immerse it into a water bath, generally at 39 to 40 degrees Celsius, we can keep consistent rewarming of that. And it's not like one particular part gets warm and then the other parts stay cold. It provides the most kind of controlled and even rewarming of that extremity. And you want it to warm kind of all the way up to that 39 to 40 degrees Celsius range. It can be quite painful, so these patients will oftentimes require like NSAIDs, like ibuprofen, or opiate anesthetics, or analgesics, so thing like fentanyl, morphine, Dilaudid, we sometimes use for these patients. And then you don't want it to refreeze for at least 48 to 72 hours after, because it's really that kind of cyclic freezing and warming, that leads to increased inflammation. That increased inflammation leads to kind of capillary changes, and that those capillary changes and kind of blockages and microclots are what really leads to that tissue ischemia, or that duskiness, and that's what increases the risk of needing amputation.
I really appreciate that. Sorry about the ignorance, but I guess yeah, you can't just do like a couple hour warm up job and be good to go. It's something you're gonna need to fucking incubate for a little while.
Yeah,
I'm
yeah.
really sorry about that.
No, please, please, anyone who has any questions, interrupt me anytime. This is why I'm here. I would love for this to be as much of a conversation as you guys make it. Um, but again, like that's for frostbite. So really, once we start seeing like some evidence of tissue injury, if you're just cold, by all means, I'm a hardcore skier myself and snowboarder. I have been since birth, essentially. Please warm your hands and feet if you're cold.
I really appreciate you.
Another
You got a lot
question
of
in the
me.
Of course.
There's another question in the chat, and that is there a role for hyperbaric therapy in higher grade frostbite?
The guidelines so far are unclear about that. So there is no significant evidence pointing towards one way or another. They kind of leave it up. Oftentimes, we make decisions on their care in consultation with a surgical service that generally tends to be vascular surgery, and we kind of let them guide the show. There has been some studies. They've so far been mostly inconclusive. But what you don't want to do are early amputations. So there is a mantra in EM saying that people will freeze in January and amputate in July. So we really want to, over time, allow the tissue to kind of self-demarcate, because oftentimes with rewarming, that kind of duskiness will recede, and the true extent of damage won't really show itself until sometimes weeks to early months later. And what we don't want to do is take more tissue than we will have ultimately needed to take if we hadn't delayed amputation. So questionable on hyperbarics. There is no real consensus there, and then no to early amputations. I see epi in a hypothermic patients is CPR only the best way. Yeah, so if again, this is a little complicated for those of us in like rigs, for instance, that don't have those epitympanic probes, or where you can't truly get a good core temperature. If you get a good core temperature and you know that it's less than 30 degrees Celsius, then defibrillate up to 1 to 3 times. Not really more than 3 times. And then I tend to recommend avoiding epinephrine until you rewarm to 30 degrees Celsius. All with the caveat that the AHA, the American Heart Association, does recommend regular ALS. However, both the European Resuscitation Council and the Wilderness Medicine Society both recommend against any kind of vasoactive agents under 30 degrees Celsius.
I'll add to this that follow your county and state protocols for this, but as an aside, you can always consult the base station to see if they want to change anything.
Yep.
And then
Absolutely.
just use that as your guide.
Yep. Again, everything I say
Everything I
is with
say.
a caveat. Follow your protocols.
Follow your
But
The
perhaps
nice
this is
thing
the
is you work at a
opportunity,
base
if
station.
you have questions or stuff like this, to ask questions of your medical directors and those who make the guidelines and protocols. Because again, these are all
Again, these are
studies that
all
have come out in the
studies that
last
have come
3
out in
years
the last
that I'm
3
going over now.
that
So
I'm
these
going
are
over now. So
new
these are
studies.
new studies.
So some of this not
So
might not be kind of
might not be
widely
kind of
used or
widely
circulated
used
yet
or
in the literature.
circulated.
And then lastly, this is kind of the last study in hypothermia that I'll go over before we switch gears and warm up a little bit. AI. AI is the big thing that we're all talking about. But ECPR, so again, the ECMO resuscitations of these patients who are very hypothermic in their cardiac arrests, require a different approach compared to normothermic cardiac arrest. The eligibility criteria are different for ECMO for these patients. So some classic contraindications to ECMO in a normothermic cardiac arrest. So for instance, if their end tidal is less than 10, they're in a non-shockable rhythm, they have an unwitnessed cardiac arrest, they might be older individuals. Those classic exclusion criteria do not apply in hypothermic arrests. So this study looked at whether AI can help us answer some of those questions. So they looked at large language models. They used ChatGPT, Claude, Minstrel, and Copilot. I'll look on the next slide. They used four agents of kind of AI compared against a panel of 11 experts trained in hypothermia, and they asked them. Or Gemini, not Copilot. So ChatGPT, Gemini, Minstrel, and Claude. And they asked them 4 questions. One, is end tidal less than 10 a contraindication to ECPR in hypothermic cardiac arrests? Is asystole a contraindication? Is absence of witnessed cardiac arrest a contraindication? And is age over 70 a contraindication? All 11 experts answered no to all of these. They had a 100% consensus opinion. When they looked at AI, the answers were a little bit different. They found that half of the AI models got at least one of those questions wrong. So it would have recommended withholding ECMO to someone who should have otherwise been considered for this therapy. And maybe even worse is that the 5 kind of AI models that reached the same consensus as the expert consensus, so they answered all questions correctly, did so either based on a completely hallucinated study and a hallucinated citation, meaning it just made it up entirely, or they came up with a real study citation, but that citation had nothing to do with the question whatsoever. So essentially, it found that AI is essentially shit for providing reliable support for clinicians in the decision-making process for qualifying patients for hypothermic cardiac arrest, ECMO, as a therapy for that. And that when we use AI in clinical practice, it runs the risk of unjustifiably withholding or withdrawing treatment from patients who have a chance of survival with good neurologic outcome. So if any of you guys are using AI to help you make these decisions, maybe reconsider this because we just don't know yet if AI is good enough for prime time when it comes to really deciding whether patients get a potentially life-saving therapy. So what ended up happening to Robert, the story I started sharing with you guys at the beginning, I got Robert in hypothermic cardiac arrest. We placed one of those intravascular rewarming catheters that I mentioned, and bilateral chest tubes, and a bear hugger. And an hour in, the temperature hadn't even risen a degree so far. So we called for our ECMO team. He was placed on ECMO and got a pulse back almost 4 hours into his resuscitation as soon as he hit 32 degrees Celsius. And by another few hours after that, he was already starting to overbreathe the ventilator. By the following morning, he was starting to move his extremities intentionally. He was weaned off of ECMO a few days later, extubated the following week, briefly reintubated after developing a pneumonia, and he actually eloped for the hospital while awaiting a neuro rehab facility not even 1 month after presentation. And that neuro rehab facility was only because he had some neuropraxia or some lasting like numbness, weakness in one of his arms. And that was probably because of the ECMO, not even because of the hypothermia. Just this winter, we had someone brought in by one of you guys, by one of the Baltimore units, who had kind of wandered off, was then found down on the sidewalk, brought in on a Friday, and by Tuesday, he walked out of the hospital alive. And that was an unwitnessed cardiac arrest. So these patients can have extraordinarily amazing outcomes. So highly that's why I'm so interested in environmental medicine. And Robert is actually what got me into my niche altogether. It's who made me kind of most interested in environmental medicine. So key points: resuscitate severe hypothermia, regardless of how dead they look. They're not dead until they're warm and dead. Avoid pacing or epinephrine under 30 degrees Celsius. And then we need those variables to be able to calculate a HOPE score to determine which patients are good candidates for ECMO therapy. That is a wrap for hypothermia. Before we move on to heat, what questions do you guys have? Thanks, Jeff. All right. Hearing nothing, let's shift gears and get a little hot here. So we're going to talk about heat illnesses and resuscitating heat stroke. So I want to start off with the story of Jordan McNair. Many of you will remember the story from the news. All of these time points are from various documents about what happened in Jordan's case. So he was an offensive lineman for College Park, starting as a freshman. He had just graduated from McDonough the previous year, and he was at football practice. The practice started at 4:15 in the afternoon, and this was in May. And by about 40 minutes later, Jordan had started to complain of some exhaustion and dizziness. He felt kind of sweaty, fatigued, wasn't really feeling well, was just given some kind of cold towels around the neck, and was kept on the field. About half an hour later, he was removed from the field because people started to notice that he wasn't quite acting right. And it's kind of hard to quantify, but they decided, hey, you're not quite acting right. Let's take you off the field. Let's give you some ice packs. About half an hour after that, he started to have some mental status changes. He was confused. He was kind of not really speaking in sensical speech. And that's what prompted a call to the team physician. So, not even EMS at this point, but the team physician 2 minutes later. So, we're about an hour and a half into his care, called to a team physician. 3 minutes later, he seizes. Okay. At 18:03, the first ambulance arrives. It was a BLS crew. At about 8 minutes later, the ambulance capable of ACLS arrives. Jordan was transported to the hospital at 18:27 and arrived to Washington Adventist Hospital at 18:36, where he was found to have a core temperature of 41.1 degrees Celsius or 106 degrees Fahrenheit, which means that from the first point when he started to exhibit signs consistent with heat exhaustion and heat illness, it was over 90 minutes before his heat stroke was recognized. He was taken to Adventist, as I mentioned. He was placed in an ice water immersion, and 12 minutes later, they got his core temperature to 39 degrees Celsius. He was admitted to their facility, but fairly rapidly transferred to the shock trauma center after his liver enzymes continued to look worse and worse. He got significant therapies at University of Maryland, including a liver transplant. All right, but he ended up passing away not even 3 weeks later, and that was from his heat stroke. And unfortunately, Jordan is not alone because over 30 NCAA athletes have passed away from heat stroke in the last 20 years alone. And that number more than doubles when you consider high school sports as well. The mortality in heat stroke ranges in literature reports from 10 to upwards of 50%. And the US death toll is climbing. When I started giving this lecture 5 years ago, the reported mortality rate or mortality numbers annually were less than 1,000. We're like 750. But the reported mortality from heat stroke is rising, and it might just be that we're better at capturing it and better at reporting it, or it might be that we are, getting worse at recognizing it, unfortunately. But we have the power to stop that. And to bring this death toll down. So my objectives are essentially to help us all know how to like what happens during heat stroke and heat illnesses. So reviewing the pathophysiology and terminology. We'll talk about cooling for heat stroke. Talk briefly about the complications of heat stroke, and then again, read just some literature from the last 3 years that may be relevant to pre-hospital care of heat stroke, which is where all the care of heat stroke patients should happen initially in the pre-hospital realm. So in order to understand heat illnesses, we need to understand heat and how we dissipate heat. So heat exchange happens through either conduction, so that's the transfer of heat from a warmer object directly to a colder object. So like ice packs work this way, right? You transfer your body's heat to that ice pack. And that at a normal kind of basal rate for humans is responsible for about 5% of our body's heat loss on any given day. Convection is the loss of heat to a moving liquid or gas surrounding you, such as to the windy air or to a pool with water. And that usually accounts for about 15% of our total body's heat loss. Evaporation is the heat loss through a change in state from a liquid to a gas, and that usually accounts for 20% of our body's heat loss, but becomes the predominant mechanism of heat dissipation when we are exercising, in which we can sweat up to 1 to 2 liters of sweat per hour. That is significant. So when we talk about needing to maintain appropriate hydration, that is part of the reason why. And then radiation is just the loss of heat through electromagnetic waves, and that usually like environmental. And that accounts for about 60% of our total body's heat loss on average. Now, as ambient temperatures and relative humidity rise, these methods that our body has to cool itself become significantly less effective. So at 35 degrees Celsius, both evaporative and convective cooling starts to become inefficient. And at humidity points of 35 is when, and 70% is when convective and evaporative cooling really become ineffective as well. So the hotter it gets and the more humid it gets, the worse our bodies are at cooling themselves. And then once our cells reach a cellular temperature of 41 to 42 degrees Celsius, that core temperature, that's really when cellular damage starts to set in, and that can trigger a whole cascade of events. So when we think about heat illnesses, they really occur on a spectrum from mild, moderate to severe. Mild heat illness we think of as one of four things. We can have heat rash, which is otherwise called miliaria rubra or prickly heat. It's essentially just a reddish raised rash found under clothed areas of the body. The way to avoid that and to treat that is just to wear loose fitting clothing that's kind of breathable clothing. So things like linen, cottons, etc. Avoiding sweating. So don't do heavy workouts if you have tight clothes. And then calamine lotion can actually help with the itchiness. It tends to go away after about a week or so. Few days to a week. You can develop heat edema, which is just benign and self-limited swelling, mostly of your lower extremities following heat exposure. This is due to just your blood vessels dilating. As our body tries to cool itself, it provides a lot of blood to the skin surface so that it can cool via radiation and evaporative and convective cooling. That blood vessel dilation can sometimes lead to swelling of your extremities. You can have heat cramps, which are generally involuntary spasms of your skeletal muscles caused by relative electrolyte deficiency, mostly low sodium. So you want to minimize exertion and replace fluids and salt orally. Electrolyte solutions are great for situations like this, such as Gatorade or vitamin water or soup, so like soup broth has a lot of electrolytes that you need so that you're not just replenishing water, but you're replenishing the salt, the sodium as well. Um, and these generally occur kind of after, like right after exercise. So you're generally fine while you're exercising. And then this is why a lot of times, like marathon runners, you'll see that they're like, they make it through the marathon. And then a mile afterwards, when they're cooling off, they start very, very much cramping up. And that's why a lot of marathon finish line tents will have like PTs on staff, physical therapists, to help work through some of these cramps. And we'll always keep broth and Gatorade stocked in the tents. And then lastly, heat syncope. So it's essentially an orthostatic syncopal event, a loss of consciousness that occurs because we just peripherally vasodilate, pool all of our blood. But the episode must be brief and with complete and rapid return to your baseline neurologic status. If this happens, you just want to remove the patient from the heat, tell them to stop working out, and then get some oral rehydration going. Now, interestingly, I had a patient who I diagnosed with heat syncope just a few weeks ago in inner city Baltimore. Things like the Four Seasons Spa still operate in the middle of the winter, and some people can overdo it in the sauna a little bit much. So it is sometimes possible that you're diagnosing heat illness in the thick of the February winter. So, but if you leave these kind of untreated, and these are your kind of early warning signs that you might be developing heat illness, you can develop moderate heat illness, and moderate heat illness is what we term heat exhaustion. This is due to water and salt depletion, and you'll essentially feel the pre-syncopal symptoms. So you'll feel that you have a high heart rate, you might feel nauseous, a little lightheaded, feel like throwing up, feel very thirsty, etc. And that's your body's way of telling you, chill, you need to drink and you need to chill yourself. But hallmarks for this diagnosis, like in order to call someone heat exhaustion and not heat stroke, their core temperature has to be less than 40 degrees Celsius. And most importantly, they cannot have any neurologic impairment. Because that is the last and most severe entity, which we call heat stroke. So as long as they don't have any neurologic impairment, you just remove them from heat, provide fluid hydration. Usually oral hydration is still fine for this stage, and then provide some kind of cooling for these patients. A fan, kind of wet towel, whatever you might need to really, really cool these people. And this is where kind of there was opportunity to intervene with Jordan. Is they kind of gave him some of these cold towels and a water bottle, but they still kept him in practice. And that is when he started to kind of continue to overheat. So they didn't catch the warning signs that he was progressing along that spectrum. And if you don't catch these warning signs, your time will burn up and you will progress to severe heat illness, which we call heat stroke. And in order for the diagnosis of heat stroke, we tend to think of it as a core temperature greater than 40 degrees Celsius with some evidence of neurologic dysfunction. And I want to talk about each one of these individually. So as far as a core temperature, what if you don't have a thermometer? What if you do take a temperature and it's less than 40 degrees Celsius, but the patient is still acting altered or ataxic, like their difficulty with fine motor skills, or they might be dizzy. So do you actually need that temperature? The Wilderness Medicine Society guidelines that were published in 2024 actually recommend that in a hyperthermic patient with an altered sensorium, meaning they have an altered mental status, and a presentation suspicious for a heat stroke. So they're out in the heat, they're running a marathon, they're a fireman going into like a burning building in July. We know that has a propensity for causing kind of overheating. They recommend empiric use of cooling and treating them as though they have a heat stroke, even if the core temperature is unknown or it's measured and it's measured below the diagnostic threshold of 40 degrees Celsius. This is for some different reasons. One is your peripheral temperature that you're measuring, again, is probably not an accurate core temperature. And what we talk about here is the core temperature. So again, remember core temperature we can measure by the esophageal probe, the rectal probe, or that epitympanic probe, which is not the same as the like infrared or a child's thermometer. It's the very specialized system. Or we could just be catching the patient in their upswing of temperature, or they could have already peaked and already be in a downswing of temperature. So we don't actually know what their core temperature truly is if we are not even catching their core or if we're just catching it in one moment in time. So if the story is consistent with heat stroke and they're altered in any way, we want to make sure that we treat them as though they have heat stroke. And then to touch on the neurologic symptoms, the cerebellum or the back part of the brain seems to be the most affected by heat and heat injury. So a lot of the findings that we'll see are really posterior circulation or the cerebellar findings. So things like confusion, dizziness, dysmetria, meaning like their finger to nose testing is significantly off, ataxic. They might have seizures, they might have unresponsiveness or coma. So there are a variety of different neurologic abnormalities that can satisfy that requirement of a neurologic abnormality for a diagnosis of heat stroke. But even something like confusion is definitely part of it. So definitely keep that in mind and don't tend to underestimate someone's symptoms if you have someone that's not acting quite right. So two different types of heat illness is what we'll hear about in the literature and what you'll hear from clinicians. Classic heat stroke essentially is, or heat illness, occurs in people who have just increased susceptibility to heat illness. So give me one moment. I just want to take a sip. So specific populations that seem particularly susceptible to the effects of heat include both elderly people and very young children. So, like infants and toddlers don't have a body surface area to mass ratio that's favorable for optimal heat loss. They don't have really efficient sweating mechanisms yet. And the elderly can have their own issues, and we'll talk about why sometimes. But elderly and young people seem to be particularly susceptible to heat illness. Patients with comorbidities. So, for instance, like we talked about in the hypothermia side of things, if you can't sense heat appropriately, either you have some kind of dysregulation with your peripheral temperature sensors, such as you have peripheral neuropathy from like really bad diabetes, or you have prior spinal cord injury and you just don't have any kind of sensation, temperature sensation abilities left. Those people can be at particularly high risk of developing heat stroke because they just can't adequately assess their need for cooling or for hydration status because they can't sense their heat. So that's kind of one bucket of people who seem to be particularly susceptible. And then people who can't vasodilate appropriately. So remember, sweating and evaporative cooling tends to be the main way we cool ourselves when we start to exert ourselves or get hot. And if you can't, because you have peripheral arterial disease or diabetes, if you can't expand your blood vessels in order to facilitate that cooling, then you will retain more heat. And there are long list of more comorbidities that I can go into and how that affects people's susceptibility to heat stroke, hyperthyroidism and stuff like that. People who are on either medications or drugs, particularly ones that dehydrate or disorient. So things like or restrict your cardiac output and your ability for your cardiovascular system to respond. So people who are on beta blockers, people who are on diuretics for their heart failure, like Lasix, can already run dry and then not have the intrinsic stores in order to appropriately cool themselves. Or something like Benadryl. Benadryl can result in anticholinergic effect and kind of inability to sweat. It impairs our sweating ability. And then obviously things like cocaine, ecstasy are sympathomimetic drugs that can A, not only prevent us from recognizing the heat stroke, but B, also contribute its own sympathomimetic response and high heart rate and sweating and stuff like that to the picture can be quite dangerous. And then even things like alcohol that affect our kind of lucidness in order to respond to our body's natural sensation of heat. And then, of course, those with either psychiatric or socioeconomic barriers that preclude them from appropriately dressing, appropriately hydrating, or appropriately seeking shelter when we go into those stretches where it's, in the 90s and hundreds, the Baltimore summers that we're all familiar with. So a lot of things that can cause people just to be susceptible to heat stroke, even if they're not exerting themselves. And then the other bucket of heat stroke are exertional heat stroke. So we see that called EHS in the literature. So it occurs in patients participating or people participating in either athletics or occupations that lead to heat exposure. So like marathon runners, but also don't forget people like construction workers who are working along like I-95 when it's 100 degrees outside and wearing long sleeves and long pants and hard hats. Those are all things that are prohibiting their natural body's mechanisms to cool themselves. Firemen, in the July summer when it's a fire and you have to wear, I don't even know, you guys know much more than me about the poundage of gear that you have to wear on you. It prevents appropriate cooling mechanisms. So the use of gear, poor physical conditioning, and a lack of heat acclimatization. So, like if someone's coming from, Iceland and spends the summer in Baltimore, and they work out, they are also more susceptible to exertional heat illness. But whichever one of these two pathways people enter in, it's all results in the same common final pathway, and mortality can exceed 30%. Now, this guy, does anyone know who this is? And I will put up his quote as well, and see if any of you guys can recognize who said this. But in the 1960s, trauma had an abysmal mortality rate as well at 40%. And through the hard work of this guy and the recognition of something he called a golden hour, trauma care has gotten significantly better. I see you guys saying, yep, R. Adam Kelly. So he was the one who mentioned that there is a golden hour between life and death. And if you are critically injured, you have less than 60 minutes to survive. And you might not die right then. It might be 3 days or 2 weeks later, but something has happened in your body that is irreparable. Okay, that was in the 60s. For the past 40 years, that same concept has been applied to heat stroke, but that time has actually trimmed to half an hour. We have a golden half an hour or 30 minutes by which we need to implement treatment, or else the body can enter some cascade from which recovery is ultimately non-survivable. And that's unfortunately what we saw happen to Jordan at the beginning of the story. Something happened in those initial 90 minutes from which he was never fully resuscitated to be able to survive. And so we have 30 minutes and 30 minutes to do what? That is to cool to less than 39 degrees Celsius. 39 degrees Celsius is our endpoint. And so how do we do this? Well, these modalities of heat loss that we talked about in the beginning are all the things that we need to augment in order to cool patients. So we have various options. We can augment radiative cooling by undressing the patient immediately and providing more surface area from which they lose heat. We can augment conductive cooling by providing ice packs to patients in certain areas of the body, like in the axilla and the groin. We can augment convective cooling by putting them in front of a fan. Make sure that air around them keeps moving. And we can augment evaporative cooling by misting, not relying on their own sweat, but misting them, allowing that water to evaporate, and that leads to cooling of the body. Now, we can also augment these techniques together. So we can augment evaporative and convective cooling together by putting a wet sheet on the patient and then angling a fan, or misting them and then angling a fan. And this is actually what they do in these units called BCUs, or body cooling units, that they use like in the Mecca pilgrimage. They just have a lot of field tents set up with these cots, mesh cots, misters on top of the cots, and fans in front of the cots. And they find that when this is done on a large scale, They can actually quite effectively cool a large number of people who overheat in the annual pilgrimage.
Could I
And
ask you
then,
a question?
yeah, please.
Um, so I'm a volunteer. So in my main job, I'm actually a subcontractor for BG&E, and I go in
Okay.
and I work on substations and the electrical grid. And there's kind of a debate going on we had the other day, talking about heat stroke and what have you. And we were talking about cooling off. Some of the guys actually like taking basically like from the cooler, the cold water from the cooler and dumping it on their head and then putting the hard hat back on. Now, other people say that's actually worse and you shouldn't do that. And other guys are like, I don't care, it's hot. And then we're going back and forth on this. So, would you recommend that? Is there any negative effects to that, or you got
It's
any advice
not
on that?
worse necessarily, and it can temporarily make you feel better. What I will say is, instead of kind of dumping that water on the head, what you'll get kind of more bang for the buck is if you keep like a spray bottle and with ice water and just mist any part of the body that stays exposed. So mist the face, mist the back of the neck, the arms, etc. And then that will provide a little bit of continued evaporative cooling, more so, and kind of that radiative cooling more so than just dumping it and then putting the hard hat back on. But that providing that ice water does for that moment in time provide a little bit of that conductive cooling because your body loses heat to that ice water. The thing with putting it on the head instead of like the back of the neck or the groin or the armpits. Now, granted, you don't want to look like you peed yourself in the middle of the day. I get that. Um, but the head can cause some issues just because that can constrict and alter blood flow to the brain itself, so it can cause things temporarily like headache or potentially short periods of confusion and stuff like that. But my guess is it's not like that degree of ice water or that much of it that it's going to cause those issues if you just kind of dump it on your head for a few seconds.
I really appreciate that. Thank you.
Yeah, of course. And then continuing on, we can augment excuse me, conductive and convective cooling together with cold water or ice water immersion. And this is where our biggest bang for the buck is. And there have been studies in both military recruits and races that showed if heat stroke is recognized and the patients are immediately cooled with ice water or cold water immersion, they can have a zero fatality rate. So no mortality if immediately recognized and immediately cooled with our most effective therapy. And when we talk about most effective therapy, how do all of these cooling rates stack up against each other? I don't know any of these off the top of my head, but and these rates when they're so low are kind of hard to conceptualize. But I think of it more so as how many minutes would it take to have cooled Jordan by using this technique? So dropping his temperature from 41 to 39 degrees Celsius, which is our endpoint. And we see that really the wet sheets with a fan, the mist with a fan, and the cold and ice water immersion are really the only ones that will achieve that cooling in time in order to help prevent the mortality. Because remember, we have that golden 30 minutes. And so this is why immediate recognition and immediate pre-hospital treatment is so important. So the NCAA actually mandates that for all games and practices, they have ice tubs set up when temperatures are reached certain points outside. We
If
have
you
these.
drop
I'm sorry.
one more thing, I don't mean to cut you off. One more
No,
thing.
please.
If you drop the temperature too fast, could that cause shock?
Dropping the temperature too fast is a good thing, and that's I'll touch on that in some of the newer studies that came out. This one came out 2 years ago that showed a rapid cooling rate is actually a good thing. So the sooner you reach that target point of 39 degrees Celsius, the less in hospital mortality you trend towards and the less total organ damage you trend towards. Ideally within 30 minutes. And then ideally you want it to be less than 38 and a half within like 2 hours. But really below 39 in those initial 30 minutes. There's no real such thing as too fast, and you generally won't be able do it too fast with any of these cooling techniques, because by the time you like recognize the heat stroke, take the patient over to the bath and then cool them, you would be at that 30-minute mark. What you don't want to do is overshoot. So the study showed, and I'll just skip over it as we get there, but since you asked the question, that if the overall temperature reaches less than 36, that's when you also start to see some complications. So it shows that when treating heat stroke, neither prolonged heat nor hypothermia is good for the body, but rapid cooling is.
Okay, thank you. I really appreciate that. Thank you. I didn't mean to
Of
interrupt
course.
you.
Please interrupt me, anyone at any time. That's I'm doing this for you guys, so make of it whatever you want. So cooling tubs filled with ice water should be at every practice, at every race. I worked the New York City Marathon in the resuscitation finish line tent for 5 years. And we had an ice bath set up at every single one, and that's in mid-November. So people can overheat regardless of the season. If this is not available, generally, and you'll be at some kind of sporting event where there should be some kind of tarp or tent or something available, and there should be somebody with a cooler and either like Gatorade or water or ice or something. This technique is called the taco technique. It stands for tarp assisted cooling with oscillation. But essentially, you put the water and the ice and the person in there, kind of like a soft shell taco, and fold it right up, and you can slosh the patient in there and provide kind of cooling rates that approach actual tub as well. And when we do this in the emergency department, we actually use body bags. And what I teach my residents and students is that for patients with heat stroke, either they should be placed in a body bag at the very beginning of their care, or they will be placed in one at the end of their care. And that is quite morbid, but also it is quite true a lot of times. And so this is why it is helpful from you guys in the pre-hospital realm, if you do have a high suspicion that the patient has heat stroke, or that they're like a code or resuscitation, but with high suspicion for heat stroke. It's helpful to know that ahead of time so that we can have this body bag on the bed ahead of time, ready to go, and we can start sending runners to get all the ice and the water in our department to be able to treat them with, because this setup does take a few minutes to do. So it's helpful to know about this ahead of time. And there was actually a study out from one of my colleagues in Arizona that details quite a nice setup to this process and how to prepare your emergency department for that. Now, one thing to touch on is medications. No role in the treatment of heat stroke. Things like acetaminophen or Tylenol work with fevers due to infections. Because when you have an infection, that bacteria or virus or whatever it is actually altering the temperature set point of our body that the hypothalamus sets. So when you give someone Tylenol or NSAIDs like ibuprofen, it can actually reset that hypothalamus back to what the body temperature should be. And that's how we lead to fever reduction. With the case of heat stroke, it's not that hypothalamus, that part of the brain that's responsible for temperature responses, it's not that has been altered. It's just that our body is so overwhelmed with exogenous or extra heat that our cooling mechanisms can't keep up. So if you give it like Tylenol, it won't do anything for temperature that's due to an elevated temperature that's due to heat stroke and not like fever. And it can actually contribute to things like liver injury. So we don't do any medications. So like we talked about, even with treatment, mortality can exceed 30%. And this is just going to be a brief touch base so you can see all the things that can happen in heat stroke. Patients can, as I mentioned, be depleted of salt in addition to water, and that can lead to hyponatremia. We oftentimes will give normal saline. They can seize either because of the hyponatremia or just because of their brain irritation. We want to make sure we have benzos and hypertonic saline prep for them. These patients can go on to develop cerebral edema and end up needing intubation, and we want to prepare for that. They can be quite encephalopathic and confused. There can be some hypotension related to not so much the cooling, but the actual heat stroke. And that's because there is this distributive shock. So usually as we cool the patients, their blood pressures may actually improve because it leads to some peripheral vasoconstriction, and that tends to kind of redistribute some of that blood volume back to the core where it should be. So we actually allow for some permissive hypotension in the initial treatment of heat patients. These patients can go on to develop cardiomyopathies. Hepatic injury is common, so liver injury. This is why anytime we see any bump in the liver enzymes for these patients, we want to really consider early transfer to a liver transplant center. The liver and the brain are the two most susceptible organs to damage from heat stroke. Bowel ischemia, so even an early sign like diarrhea can portend dead gut. These patients oftentimes end up getting a lot of fluid resuscitation, so can go on to develop ARDS or a really bad respiratory failure. They can develop renal failure, rhabdo, and just like in hypothermia, DIC or disseminated intravascular coagulation. So these are the cases where people will just like bleed and clot and bleed and clot, and that whole clotting cascade is completely dysregulated. And these people will bleed out of everywhere. So I was an early attending at PG Hospital, the old PG Hospital, and we were brought a patient who must have used all of the cocaine in DC that night, and was then like chased through, and it was the middle of the summer, chased through like multiple yards and streets for like mile, ran over things, like had fallen, scratched himself on fences and everything, and was finally brought to us and was in heat stroke. Like his core temperature was 42 degrees Celsius. He was already tachycardic to the 140s. And as we cooled him immediately, but he had probably been hot for a long time because it was both hot environmentally, but also hot from his kind of sympathomimetic kind of ramped up system. And over the course of the next 6 hours, we essentially just watched him bleed to death from everywhere, from every scrape, from every like pore. It was one of the most gruesome things that I have ever seen. And that was all because that we did not catch that heat stroke when he developed it, probably because he had developed it long before he got to EMS or to us. And something had happened again from which survival was not possible. He could not recover. And so DIC is really, when you actually see it unfold, it is gruesome and truly horrible. And so because people can go on to develop all of these complications, we tend to actually get a few kind of serial labs. So we'll get an initial set of labs. We'll get either a 2 hour or a 4 hour set of labs, depending on how abnormal the first set was. And a lot of these patients will actually end up going to the ICU for care. And then some recent literature updates, ones that are hopefully a little more relevant to you guys in the pre-hospital realm. I just see a few comments. Vehicle air conditioning, extremely important, especially in this region. And vehicular deaths actually due to leaving kids in the car or pets in the car, or you forget like grandpa in the back seat who fell asleep. Please don't forget people in seats, because so many people die every year from being trapped in hot cars, and it's awful. It's an awful way to go. So definitely vehicular air conditioning, important. So association between cooling temperature and outcomes. This is the study I talked about. The cooling rate within the first 2 hours, the faster it is, the better patients did. And then, however, the overall body temperature, and again, I'm just going through this quickly because we kind of talked about it before. If it reached less than 36 degrees Celsius at any point during their resuscitation, the first 24 hours, they tended to have worse outcomes. So it showed that both hyperthermia and hypothermia are associated with adverse outcomes in heat stroke. So patients with heat stroke have better outcomes when they are cooled very rapidly, but then stabilized at a slightly higher temperature. So temperature over 36 degrees Celsius. What about cooling modalities? So cold and ice water immersion is the gold standard for treatment of exertional heat stroke patients. The cooling rates are reported anywhere from like 0.1 to 0.35 degrees Celsius per minute, but it's not always possible. Availability of resources and personnel may limit the effective implementation of immersion cooling. So this study looked at whether ice sheets can be used instead. So this was a study actually done by the Fort Benning Emergency Medical Services over a 10-year period. They looked at A whole bunch of heat casualties and ultimately 462 patients, 336 of which were cooled with ice sheets. They kind of didn't look at the 50 that didn't get cooled, and then they looked at the 49 that got cooled with cold water immersion. So they found that when you looked at all comers, so all of the patients who were cooled with either immersion cooling or ice sheets, they had cooling rates of 0.12 degrees Celsius per minute and 0.07 degrees Celsius per minute. That 0.07 degrees Celsius per minute rate doesn't quite cut it. For the treatment of heat stroke. But when they separated out patients who started at temperatures less than 39 degrees Celsius, who didn't probably need to be cooled all that much to begin with, and then patients who had starting temperatures over 39 degrees Celsius, they actually found that those who had initially higher starting temperatures, so those who had heat stroke, had faster cooling rates with ice sheets. Of 0.16 degrees Celsius per minute. So they concluded that in cases of exertional heat stroke, ice sheets may be a viable alternative. And these are literally just sheets that were kept in a cooler with ice water on the rig. So they may be a viable alternative, especially when patients are starting with higher core temperatures. And then this was another study that also looked at ice sheets. They saw 36 runners with diagnosis of exertional heat stroke, meaning they had both a core temperature greater than 40 degrees Celsius in the study and some evidence of altered mental status. They applied ice water sheets that were changed out every 2 to 3 minutes with additional ice packs in the axilla and groin. They found that 100% of these runners reached a core temperature reduction less than 40 within 30 minutes, and 91% reached core temperature reduction less than 39 degrees Celsius within 30 minutes. And they found an ultimate cooling rate of 0.12, which is well within the recommended rate of about 0.1 to 0.15 degrees Celsius per minute. So the ice water soak sheets may be a reasonable alternative for the treatment of exertional heat stroke. I can't see a problem with rigs carrying a cooler with ice water and sheets for those summer months where we expect to see a lot of heat stroke, and especially good, like we can keep these at multiple points along races and at practices and stuff like that. If these rates really are what the literature has shown that they are, it may be a viable alternative to cold and ice water immersion, even though cold and ice water immersion still remains the gold standard. So Wilderness Medicine Society most recent updates in 2024 for the treatment of heat stroke. Rectal temp is the preferred pre-hospital core temperature measurement. We want to do active cooling empirically with any patients with altered mental status and a presentation concerning for heat stroke, like we talked about earlier. Ice water immersion is first line therapy, and no dantrolene or antipyretics, meaning like Tylenol, for the treatment of heat stroke. The Society of Critical Care Medicine guidelines also came out last year in 2025. It was an international panel of experts from multiple medical services, including emergency medicine and pre-hospital people, as well as emergency and inpatient settings. They came out with 2 recommendations that were based on overall low quality evidence, just because there isn't a lot of evidence, but they recommended active cooling methods. They have a whole chart of them. Again, ice water and cold water immersion will result in the fastest rate of core temperature reduction. And then they recommended against the use of dantrolene. It's a medication that we use to treat malignant hyperthermia, which is complication of anesthetic and some other medications. There was some initial thought that this might be used in the treatment of heat stroke, but they recommend against it. And then prioritize cooling methods that reach the most rapid rate of cooling, so ice water and cold water. Similar cooling strategies for either classic or exertional heat stroke. Choose the cooling methods that will reach a target temperature within 30 minutes. Prioritize cooling modalities that have a cooling rate greater than 0.15, and the routine use, again, of Tylenol, NSAIDs, and salicylates like aspirin should be avoided. European Resuscitation Council guidelines for first aid also mentioned heat stroke, providing passive cooling, active cooling, and they also included a graphic of that TACO technique, the TARP assisted cooling with oscillation technique, and then continue the cooling en route to the hospital. So overall, heat stroke, core temperature greater than 40 degrees Celsius with some degree of altered mental status, but the core temperature isn't absolutely necessary for the diagnosis. Cold and ice water immersion, and then liver failure tends to be a big complication. Awesome. I don't think that we are going to get to to drownings this time around. I will be happy to come back in the future and talk to you guys about drownings as well. I want to be kind of cognizant of your guys' time. I have a question. Do these strategies apply to drug-induced hyperthermia too? Drug-induced hyperthermia, we don't want them to be at core temperatures greater than 41. So that same thought applies that if they have core temperatures greater than 41, that will lead to cellular damage, but the treatment can be different. So for things like malignant hyperthermia, we have dantrolene. For like serotonin syndrome or other things, there are different modalities that we can use as far as drugs. Any other questions? In the comments.
I will take you up on that future lecture.
Happy to come back at any time. I already have it made.
That's good. Summer is coming. Swim season.
I'm going to stop share so I can see the comments more easily and see all of you guys.
People who are
awesome.
Interested in MIMS credit, please use the link to sign in so we can process that. Very informative. And
thank you guys.
You are very into your topics, which is excellent. You're a very energetic lecturer, and we appreciate that.
I appreciate it. And again, it's so easy. It's easy to be passionate about it because this is stuff that we do even in our own activities. So like I mentioned, I'm an avid skier and snowboarder and a hiker and swimmer. I used to coach swimming and lifeguarding. Like these are all things that it's not just important to know so that you can make the difference between someone's life and death, but important to know even for yourself and for your family and friends. You never know when this will come in handy.
I really appreciate it. This was informative and it was pretty interesting. Thank you.
Awesome. Feedback for me was this at a level. I know that there is a wide variety of people joining this call at a level that's understandable.
I think so.
Awesome.